Shall we start, Niels? Okay. So good morning, good afternoon, good evening, and welcome to the fifth webinar of this Culture and Health webinar series of 2020. My name is Sanjoy Bhattacharya. I am the co-director of the WHO Collaborating Center for Global Health Histories at the University of York in the United Kingdom. I also teach history of medicine. The webinar you're about to listen to and hopefully participate in, do ask questions through Slido, is part of a series which is funded by the Wellcome Trust and the product of a collaboration between the WHO Regional Office for Europe, the WHO Collaborating Center for Global Health Histories at the University of York, as well as the WHO Collaborating Center on Culture and Health at the University of Exeter, also in the United Kingdom. The webinar series examines important and timely topics at the intersection of health, well-being, and culture. It intends to create a forum that brings together experts from the humanities and social sciences, senior officials from the WHO and other United Nations agencies, voices from non-government organizations, think tanks, and civil society. And of course, the wider public to exchange ideas and perspectives, exploring the social, political, historical, and cultural context of health. During this webinar, our panelists will spend the first 30 minutes making brief opening statements about today's topic. The role of culture in defining and advancing well-being in relation to a very important theme, the possibility of malaria eradication. The remaining 30 minutes will be dedicated to a discussion, including questions from you, our online audience. If you would like to ask a question, please go to www.slido.com and enter the event code, which is #WHOCH, all small. You'll also be able to vote questions up or down. Please also be aware that we have a questionnaire up on the Slido page, which helps us to evaluate and improve these webinars. Please do take the time to fill this in at the end of the webinar. And if you'd like to be kept informed about these events, please also leave your email address so that we can get in touch with you. In today's seminar, we examine the claim recently made by the Lancet Commission on Malaria Eradication that it would be possible to eliminate malaria by 2050. Focusing on the historical trajectory of artemisinin, this webinar discusses the claim made by the Commission and asks the following. What does artemisinin tell us about the prospects of malaria eradication? To what extent is the effectiveness of this drug being impaired by growing drug resistance? And last but not the least, what role will community engagement efforts play in enabling a malaria-free future? We are joined today by three distinguished speakers. Professor Ian Graham, who's Director of BioYork and is also the Western Chair of Biochemical Genetics at the University of York in the United Kingdom. Professor Karen Barnes, who's Professor of Clinical Pharmacology at the University of Cape Town, Head of Pharmacology for Worldwide Anti-Malarial Resistance Network, and co-chair of the South African Malaria Elimination Committee. And not least, Professor Rajitha Wickramasinghe, who's Professor of Public Health and former Dean of the Faculty of Medicine, University of Kelaniya in Sri Lanka. we are going to be short of time, so I also very quickly want to thank our colleagues at the WHO Regional Office in Copenhagen for helping us put this event together and doing a very large amount of work that goes on in the background to put these events together. So thank you, Dr. Niels Fittier and Andrea Scheel, much appreciated. So I'm delighted now to hand over to Professor Ian Graham. Ian, please, the floor is yours.
Thank you, Sanjoy. Could we have the slides up, please? So I want to start by just reminding everyone that malaria is still a major killer. In 2018, approximately 405,000 deaths were recorded according to the WHO report of 2019. And the WHO in trying to prevent the development of resistance to the main drug that's used to treat people suffering from malaria, artemisinin, recommend that it's used in combination with other anti-malarial drugs in order to prevent that resistance developing. In 2018 also, there was 214 million ACT courses delivered by the national malaria programs, of which 98% were in WHO Africa region. So that gives you an impression and an idea of how important artemisinin is as a first-line treatment against malaria, and the importance of production stably of artemisinin and its provision to people who need it as a combination therapy. So we were tasked by the Bill and Melinda Gates Foundation, in fact, close on 15 years ago now, to improve the production of artemisinin, which is it's a sesquiterpene molecule. In this slide, you can see the molecule. It's produced in these amazing structures, which are trichomes on the surface of the leaf or leaves of the plant called Artemisia annua. And this plant has been used in medicine for more than 400 years for the treatment of fevers, including malaria. And its structure of artemisinin was determined in China during the 1970s. So the structure of this molecule was determined, and in fact, Tu Youyou, the Chinese woman, was awarded the Nobel Prize in 2016 for her great work on the discovery of this molecule. One of the issues with the molecule and the production in the plant is the yield, and that's what our work was focused on. So during the next few minutes, what I want to do is to give you an idea of the work that we've done and the work that needs to still be done in order to carry on production to meet demand of this extremely important molecule. The next slide really just reminds me to say that we started off this work by determining the genetic basis of the production of artemisinin in this amazing plant. We
Ian, we've lost you. If everyone could just bear with us, I think Ian is trying to log in again. This is the only downside of online events. So we still have Niels online, which is important because he's sharing the PowerPoint presentations.
Yes, maybe I can introduce myself from the background real quick. It seems that we've had some issues with Ian. He might have dropped out of the call. So we'll give it a couple of minutes. Hopefully he'll be able to rejoin us. Otherwise, Sanjoy, I suggest we maybe move on to Karen and Rajita and pick up with Ian subsequently.
All right, so we'll give it a minute, and then
yeah.
You know, theoretically, it's so wonderful to have these online events because it's environmentally friendly, less travel and stuff. But yeah, I must say this is the first Zoom event in which we've had a speaker's internet go down. So generally speaking, it is reliable.
I mean, my suggestion would probably be to continue with you, Karen, if that's okay. All right with you, because I'm not sure how long this will take, and we do have a limited amount of time. So, Karen, if that's all right with you, I'll share the slideshow again, and I'll just skip forward to your slides.
Perfect. I'm very happy to start.
Let me just.
So maybe I'll start while the slides are coming up. I've been asked to speak about community engagement, and the examples I'd like to give are from 2 regional initiatives in Southern Africa. Next slide, please. As Ian was starting to tell us, we've got some really strong tools that have advanced the control of malaria and aided its elimination in some countries, Sri Lanka included, which we look forward to hearing more about. But each of these tools really depends on community buy-in, community acceptance of what needs to happen. So to control the mosquito vector, we need indoor residual spraying or for people to sleep under bed nets. For the artemisinin combinations to do the remarkable things that they've done in curing patients and in reducing malaria transmission, we need people to seek treatment early before they progress to severe disease and also before they start transmitting that malaria onto other people. And we need for them to finish their treatment course. And the artemisinins generally work so well that a lot of people will feel better within 24 hours. And so it takes a lot of community engagement to help them understand why they want to finish the tablets of the treatment course rather than saving them for the next malaria episode in their family. And lastly, we need community engagement to help people be available for and support the very important surveillance that needs to happen to understand how people respond to treatment. Are they cured? Are there factors around a homestead that might put them at more risk of malaria? So community engagement is really essential for all these wonderful tools we have to do their job. Next slide, please. Unless you are working on a remote island, malaria transmission knows no borders, it knows no boundaries. A mosquito vector doesn't need a passport, nor does the malaria parasite. I work in Southern Africa, which is a beautiful part of the world, and we have borders that are in rather arbitrary places for historical reasons. And we often have families and communities living on both sides of the border. We also have very porous borders, as you can see here. The top right picture shows you the border between Mozambique and South Africa, where a market has been set up, an informal market, and there's actually a place that you can walk through. It's very easy to cross the rivers that are part of our borders, or to climb underneath the fences that are trying to separate countries. Another way of demonstrating how interconnected we are is the top left picture, where you can see how Southampton University has tracked mobile phone use and the calls that are made. And you'll see how the Southern African borders, especially in Southeast Africa, are really, really interconnected. Next slide, please. The first example I'd like to tell you about is something called the Lebombo Spatial Development Initiative, or we fondly call the LSDI, which was a government initiative between Mozambique, South Africa, and Eswatini to try and advance economic development in the area shown here. One component of encouraging economic development, and particularly tourism, was to improve malaria control with a range of measures, including strengthening of indoor residual spraying to reduce the population of the mosquito vector. Luckily for us, we mostly have indoor resting mosquitoes here, so this is a very effective strategy. It also involved the introduction of the artemisinin combination therapies that Ian's going to talk about, and the switch to a definitive diagnosis with the malaria rapid test. And this program started in 1999, so I think it's an important part of history in this region. Next slide, please. As I mentioned, one of the activities was strengthening indoor residual spraying. And what was, I think, particularly successful about this initiative is that these were community-based spray operators. The community selected who they would like to become spray operators in their area. And I think trust between a malaria program and a community is absolutely essential. And these are people that need to walk into your home. They can see your things, they can take your things. So they need to be people you can trust. And in areas where you don't have community-based spray operators, we often have problems with significant lockouts, people refusing to allow people into their home. The community wasn't just involved with selecting the spray operators. We had over 138 people volunteering to having window traps like the one shown in the top right put into their windows. And this household then became part of the surveillance. The window traps were trying to find and count mosquito vectors. Every day, the community member would empty the trap, keep it in a little bottle. At the end of the month, the program could come around and see what was happening to the mosquito population. And fortunately, we saw nicely that the mosquito population decreased because of these community-based spray operators. Next slide, please. Another aspect, community-based aspect of this program is finding a way to bring malaria diagnosis and treatment closer to home. A lot of the communities most affected by malaria live in remote areas which are not well served with clinics and hospitals. And this initiative of the Mozambique government allowed the community to select someone to be their health worker. They either not paid at all, paid a very small amount, but they're part of the health system. They get supplied with essential medicines in a little kit that comes each month. And we brought them into the LSDI, taught them to do definitive malaria diagnosis with rapid test, and taught them how best to use artemisinin combinations to treat malaria and when patients needed to be referred. And so this was another very important component of the LSDI. Next slide, please. I haven't had time to go into the other ways of community engagement, but I should mention here that it's really important that you integrate community leaders, whether they're church leaders, traditional leaders, sometimes school teachers. They also help build trust between the community and a health program. With all the interventions together, you can see here in all the areas that were involved in the LSDI, how there was a steady decrease in the number of children who were infected with malaria over the duration of the program, taking some areas from close to 90% down to 5% prevalence over the period. Next slide, please. Previous slide, please. One of the things I wanted to highlight about this graph, because the general trend is so good, we sometimes don't notice what's happening with this yellow line. And I think this is important to show that there was one area where there was great success with the program, and then unfortunately resource constraints had to stop the program in that area for a couple of years. And you can see how quickly the malaria bounced back. Luckily, then the Global Fund came on board and helped with providing additional resources, and then we could restart the program in that area. But I think this does illustrate how fragile gains are that one can make in malaria control and how quickly these can be lost. Next slide, please. One of the reasons why I think the community involvement was so strong throughout this program, both in Mozambique and in South Africa, is that we were dealing with communities that were severely affected by malaria. 1/3 of households had catastrophic costs associated with malaria in Mozambique, and 1 in 10 households in South Africa had similarly catastrophic costs. And this is in an area where treatment is either provided for free in South Africa or at a nominal cost, very low cost in Mozambique. But there are all sorts of other costs involved with getting to health facilities, etc. So these are communities that know how bad malaria is. Most people know someone who's died from malaria, and they've often had malaria themselves. Next slide, please. It's a very different situation if you're in a pre-elimination context. You're in an area where there's very, very low malaria transmission. Most people in the community have never had malaria, and they don't know anyone who's had malaria. And this can cause problems for malaria programs because people then don't see the need to allow their houses to be sprayed. They don't see the need to sleep under a bed net. If they feel sick, they develop a fever or other malaria symptoms, they don't see any urgency in seeking treatment, even though the WHO and we all advise that malaria symptoms, you need to seek treatment within 24 to 48 hours. Even if they do get to a health facility, those health facilities have so many other things that they worry more about than malaria. So if someone comes in with a fever, they often forget about malaria and don't do a test. And then there's a late diagnosis, and that can increase disease severity. So it's particularly in these pre-elimination contexts that we need to intensify community engagement. And because of the regional nature and our populations being mobile and migrant, we need to remember to engage not just with the local populations, but also with our mobile and migrant populations. Next slide, please. So the other example I'd like to take you to is a current initiative called the Elimination 8, which is a collaboration between the governments of 8 countries in Southern Africa. The ones in blue are what are called frontline countries, and one hopes that those are the countries that will eliminate malaria soon, and then the control in the subsequent countries will progress to elimination thereafter. So here I'm focusing on those frontline countries, Namibia, Botswana, South Africa, and Eswatini. And you can see in this graph how there was a steady decline in the burden of malaria since 2000. But unfortunately, in the last few years, we haven't really seen much of a decline. And in 2017, we had a worrying malaria outbreak across the whole region. Each of these countries suddenly saw a massive increase in their number of cases and taking us back to where we were in about 2010. We had to think hard about why are our malaria programs failing us? Are we dealing with insecticide resistance? Are we dealing with drug resistance? Are we having failure within the community's acceptance of the program? What's going wrong? And next slide, please. I think this was a really good time to have a team involved who had incredible skills in community engagement. And this was led by the Isdell Flowers Foundation. And they have a cross-border malaria initiative between Angola, Namibia, Zambia, and Zimbabwe. And they include everybody. All stakeholders are actively involved, from representatives of the malaria endemic communities, their churches, non-government organizations, the governments, and other parties. And their roundtable last year helped us crystallize out some of the core principles of community engagement. And I think that this is important to pay attention to. Communities are not all the same. And of course, because of that, you can't have the same engagement strategy for all communities. There's no one size fits all. Another key message, which I think doesn't get enough attention among technical experts, is that community engagement must be bidirectional. It's not just a case of the government or the technical experts telling communities what to do. You have to find a way of hearing what the communities think, what they like, what they don't understand, what they need more of. And we really do need community members to be at the heart of malaria elimination efforts. During this roundtable, there were some quotations which I found particularly powerful. One from the Zambian Minister of Health was, he said that we will not have success in eliminating malaria if we do not engage effectively with the community. And Phil Tuba of the Matcha Research Trust said we need bidirectional community engagement between scientists who are experts in science of malaria and the local leaders who are experts in their own realities. Next slide, please. So in this very quick 7 minutes, I hope I've persuaded you that malaria controls have been made, but these are fragile. So we must remember to keep getting the basics right. Regional partnerships are extremely valuable, at least in my experience, and I don't think we would have made any progress towards elimination without them. And lastly, community engagement is absolutely essential. And I think this is summed up very well in the concept of the campaign stating that zero malaria starts with me. And I'd like to end with a quote from Neville Isdell, who is a co-founder of the Isdell Flowers Foundation. And he says, the people in the community know the problems and the solutions, and it's up to each individual person to take responsibility. And I think that's true whether you're a mother who has a baby who has malaria or you're the Minister of Health. Thank you so much.
Thank you, Karen. And I think Ian has rejoined us, so perhaps we can move to Ian again. Thank you, Karen.
Yes, my apologies for losing connection. I'm back again. So if we come to slide 3 of my presentation, please. I think that's where we got cut off. And I will skip through these and return to them during questions since we have some time. So basically the work that we did using molecular breeding resulted in hybrids which have improved production of both biomass and production of the molecule itself inside the biomass. And that leads to then better production by smallholder farmers and better extraction capability at the local extractors that are used for production of the drug. And you can see we trialed in a range of countries around the world, China, India, Madagascar, and Uganda in particular. And we got significant increases in yield of artemisinin. And the next slide shows the main impact over the last 5 years is that the hybrid seeds produced in our Centre for Novel Agricultural Products in partnership with East West Seeds was sold mainly to commercial operations in Africa and were sufficient to produce up to 200 million artemisinin combination therapy treatments. Achieving this impact required producing competitive hybrids, maximizing the reach by engaging the East West Seeds as a commercial partner for distribution and production, and adopting good practice, which was essential for the Bill and Melinda Gates Foundation as well, so that our seeds were only provided into the ACT supply chain and not provided for monotherapy use. And then engaging Artemisia growers and extractors to maximize the overall impact through agronomy and trial. The next slide, if I may, please. Takes me on to mentioning that despite those good hybrids, and up until we produced those hybrids as well, the world's supply of artemisinin has been extremely erratic. This publication from Nature in 2016 summarizes that in the graph on the right-hand side, which shows artemisinin price for over the years from 2000 to 2015. And that fluctuation price is brought about by a fluctuation of supply and demand. And that motivated a group in Berkeley led by Jay Kiesling to develop a microbial-based production platform for production of artemisinin, so that ideally producing the drug in yeast, in microbes, would level out that fluctuation in supply. And this report in 2016 summarizes essentially that although the production of the molecule in yeast, a precursor molecule, was successful, that it still was not able to compete with the plant-based production, which was still coming in at $250 per kilogram, whereas the semi-synthetic route for production is still more expensive than that. So unfortunately, that led to this route not being adopted. In fact, in 2013, it was representing something like 8% of the global supply. By 2015, it was back to zero, and plant-based production still today predominates. The next slide is just summarizing work that we did to better understand, and I'm drawing your attention to it, research that we did to better understand how the molecule produced, and cut a very long story short. Essentially, plants, because their structure, are able to carry out both biology and chemistry to produce artemisinin. When you engineer its production in microbes, they can do the biology part, but they cannot do the chemistry part. And that chemistry part has to be done in a separate chemical operation, which adds to the cost. And so until today, the efficiency of production and cost of production in plants is still cheaper. And in fact, the Bill and Melinda Gates Foundation are still running competitions to see if they can get more efficient production platforms that would drive down the cost. The next slide just serves to remind me to say that this is still a very active area of research, and this is just one example of a series of papers that have recently been published in one of the Frontiers journals, and you can see the community of researchers in this area to improve our understanding of the plant-based production system and microbial-based semi-synthetic production is still very, very active. And it's active in terms of improving production. It's also active in terms of understanding if there are any other bioactives in the plant and could they be used along with artemisinin. and some work that we have done ourselves is shown on the next slide, or noted on the next slide, please. And that draws attention to a very recent WHO report, which they show position on the use of non-pharmaceutical forms of artemisia. Now this can be a big problem, because if, as we know, if you do not use artemisinin as a combination, then it greatly increases the threat of resistance, of the parasite developing resistance to the drug. And this is the case if it's used as a monotherapy. And this paper, which was from our group, which was noted in this WHO report from last year, basically demonstrated that the molecule that is killing the parasite is artemisinin. There are claims that other molecules present in plants, when it's used as a herbal remedy, for example, such as flavonoids in this case, are also active in combination with artemisinin. But our work showed that in vitro, it is only artemisinin which is effective. So this, along with other research, clearly demonstrates that there is a real threat of using monotherapies and using medicinals, because they're essentially like using a monotherapy in terms of the threat of resistance. So there's still much research going on to clearly demonstrate that and to support that long position of the WHO. The next slide, please. Just quickly summarizes the lessons learned. I'm not going to dwell. It's essential, as the last speaker was saying, to engage with the community to understand what the community needs in terms of production and extraction, as well as doing your research on laboratory-based results. And the main lesson learned is it's really important to share data, to share material, to share tools, and all of this work which we've done, we have shared widely, both in terms of our know-how and in terms of the tools to improve production even further. And the next slide is just to emphasize some of the future challenges. It would be great to get a really effective alternative production platform to level out that cycle of supply and demand, or to improve plant production even further so we can level out that supply and demand. It's really important to debunk some of these claims regarding artemisia use so that we continue to focus on using it as a combination therapy treatment. And I think it's also important that we maintain advocacy for plant-based production, because even today we're still absolutely dependent on plants for production of artemisinin, and it can be dangerous if farmers and producers in countries like China and Madagascar, for example, if they think that there's just a wonderful new production platform around the corner, then it really turn them away from their commitment to producing artemisinin. And in terms of supply chains, it's not only to control the price fluctuations, but to protect against emerging parasite resistance to artemisinin by focusing on those combination therapy treatments and just supplying to producers who are committed to using their product going into combination therapies. And I think that takes me on to the last slide, which is just to thank all of the people that have done the work. I won't go through everyone, but particularly the Bill and Melinda Gates Foundation and the Garfield Weston Foundation, who continue to support us to provide some of the research and some of the assistance to maximize the impact of the work that we've done. And I should also mention Bionics in Madagascar, who have been the real center for our field trials and continue to use our hybrids for production of artemisinin for artemisinin combination therapies. And I think with that, I will finish. Thank you.
Thank you, Ian. Thank you very much. So can I now invite Rajita to present, please?
Yeah. Thank you, Sanjoy. First of all, let me thank the organizers for inviting me to this webinar. Can I have the first slide, please? Right, so what I would be doing is talking about malaria elimination, the Sri Lankan experience. Can I have the next slide, please? Right, what this animation is showing you is how malaria was eliminated region by region over a period of about 10-12 years. Next slide, please. Now this slide gives actually the history of malaria control in the country. The anti-malaria campaign was established in 1911, and it took us over 100 years to finally eliminate malaria. As you can see, that large peak in 1934-35 was a devastating epidemic that affected about, or there were about 1.5 million cases in a population of 5 million and resulting in about 80,000 deaths. Then we embarked on a malaria eradication program in 1958. And in 1963, we reached near elimination with only 17 cases being reported, of which only 6 were indigenous. Then malaria came back again, and then towards the end of, let's say about 1999, since then, there's been a gradual decrease, and Sri Lanka embarked on a malaria elimination program in 2009, and the last indigenous case was reported in October 2012, and we were certified malaria-free on the 6th of September 2016. Can you click, please? So during this period, we also had a 30-year-long conflict going on in the country, in mainly the malaria endemic areas. Click again. And then this is where we started a malaria elimination program, with the last case being reported in October 2012. And then click again. And then WHO certification in 2016. Next slide, please. So what made malaria elimination possible in Sri Lanka? Basically, this was a country decision that was taken in 2008. And this was taken against the backdrop of several decades of good malaria control and a decreasing malaria incidence over the years. Now, the leadership for this program was taken by the malaria control program itself, and basically the implementers were the anti-malaria campaign of the Ministry of Health, and 2 local NGOs who were principal recipients in GF grants. And there were no other implementing partners. Next slide, please. Right. So this is a close-up of the of malaria in Sri Lanka during the last 10 years. And as you can see, the malaria elimination program started in 2008-9, and then how the cases dropped over time. Could you click, please? And all this during a civil war which lasted from 1983 to 2009. Next slide, please. So what was the strategy that was adopted for elimination? This was phased out realistically in both time and space. Then we embarked on the elimination phase. Our objectives were to eliminate Plasmodium falciparum by the end of 2012 and Plasmodium vivax by the end of 2014. The interventions, basically universal access to diagnosis and treatment and vector control. There was attention to specific details. Radical cure was what was intended. Implementation, there was coverage in access to healthcare. We have excellent public health system. We have good road and connectivity and transport networks. We also have a literate population, and also there were no counterfeit medicines in the market. Even during the separatist war, malaria commodities were provided to rebel-held areas. And malaria control was decentralized to a great extent, but also there was a vertical element incorporated in the structure of operations. Next slide, please. So in short, it was nothing but good public health practice. Next slide. So what lay behind the success of malaria elimination effort in Sri Lanka? Click. So we have basically reported these in a publication which is accessible to all. Next slide. So then we looked at whether malaria elimination costs more than malaria control. Next slide. Right, click again. So we looked at this period. We tried to get at 2 periods here and to see, compare the costs of control versus elimination. Next slide. Yeah, click again and click. And another click. So we looked at this period from 2002 to 2012 and from 1981 to 1989. And we chose these 2 periods because, as you can see from the arrows here, pointed arrows, that during these 2 periods, the incidence was similar, but we wanted to see why it increased in the period from 82 to 89 as compared to the period beyond 2002. Next slide, please. Yeah, click again. So here in this graph, you see the malaria cases in the dotted blue lines and the malaria expenditure given in the red lines during these 2 periods. And the average malaria expenditure during the control phase and the elimination phase was similar at about $30 to $35 million a year. Next slide. So the proportion of external versus government funding for malaria control during both periods was similar. It was around, on average, about 24% and ranging from 13 to 38%. Click. So during 1980 to 89, we had bilateral funding from agencies such as USAID, as well as governments of UK, Netherlands, Japan. And these funds had to be strictly dispersed in accordance with government regulations. Click. Now, during the period 2002 to 2010, we had funding only from GFATM. Now, GFATM funding, basically they have their own disbursement criteria on agreed terms, and replenishments are tied to a performance framework. So this funding was more flexible in the sense that you could do things which otherwise the government regulations do not provide. Can you click twice? So basically the GFATM funding was flexibility in disbursement compared to the rigid rules in the case in the earlier period. Next slide. Then we looked at the different expenditure categories during these two time periods. And if you see the circle on the right, the pie chart, you can see the majority of the funds were spent on insecticides, ITNs, and spraying materials, whereas in 2010, a majority was spent for management and other costs. There is also a very important component seen here, and that is monitoring and evaluation, which you see in the 2010 pie chart, and that is because GFATM funding had to have a dedicated amount for M&E, which was not there in the case in 1989. Next slide. So the key lessons from the malaria elimination success of Sri Lanka is that elimination is possible with current tools. A sound strategy is necessary. Can you click, please? And malaria elimination does not have to cost more than malaria control, but there is a strategic shift in the implementation that is important. The program must also be agile and flexible to respond to the ground realities. Financial support, at least a component of it, needs to be flexible in its disbursement, and M&E plays a critical role in improving program management and increasing efficiency. Click. So, donor funds for health programs actually may yield better outcomes if they are channeled through well-managed multilateral funding agencies than through bilateral avenues. Next slide. So as a postscript, actually we had introduced case of malaria reported in December 2018. It was the only case, and the anti-malaria campaign was successful in preventing further transmission. Click. So this is reported. This has already been reported. And next slide. I'd like to thank Professor Kamini Mendis for sharing some of her slides. Thank you very much.
Well, thank you. Thank you for three extremely thought-provoking presentations. Karen, I wonder if you want to just quickly come in on the issue of resistance, broadly defined.
Thank you, Sanjoy. So I think artemisinin resistance is something that all of us as presenters are very concerned about and is a global threat. The way in that the threat works is that if artemisinins don't work well, they don't only slow down the clearing of parasites, but there's an increase in gametocytes, so potential increase in transmission, and there's more pressure on a partner drug, even when drugs are used in combination. So those partner drugs start to fail too. And there are some places in Southeast Asia where there are quite frightening levels of treatment failure. Over half the patients treated are not cured by these recommended artemisinin combinations. So that's one big area of concern. The other area of concern is for how long will artemisinin resistance be primarily a problem in Southeast Asia? Historically, things have spread from there to the rest of the world. We're now getting isolated reports from elsewhere in the world, and the impact on malaria cases and deaths if the resistance spreads to the Indian subcontinent or sub-Saharan Africa or South America is quite frightening to think about. And we'll stop talking about elimination for a long time if that happens. Thank you.
Thank you, Karen. We have a question online via Slido. Do you think we will continue relying on artemisinin for the next 20 years to eradicate malaria? Or is there any hope of deploying novel non-artemisinin anti-malarials? I wonder if the speakers have anything to say on this.
So perhaps I can start. I mean, there's a lot of work going on to develop novel anti-malarials. There's some quite exciting prospects, but at the moment, they're not available quickly enough for the needs in Southeast Asia. And to have all the attractive properties of artemisinin combinations and of artesunate that's really saved a lot of lives we're going to have to hold thumbs that the new products reach that target. Perhaps Ian wants to add?
Yes, there is a number of candidates in the pipeline. The timeline is stretched out, and we desperately do need alternatives because it's be described as an arms race, and the parasite is always evolving to develop resistance. And rather than point to anyone specifically, I would just emphasize that it's extremely important to continue that research, to look for other drugs as well that once they're discovered, they can be used, produced, and as for malaria.
And Rajita, would you like to add anything to this?
Yeah, I mean, actually during the last maybe 20 years or something, there have been some 3 major discoveries that have been made, which have contributed a lot to malaria control. One is, I think, the LLINs, ITNs, and then we have the RDTs, and then for treatment we have the ACTs. So I think it has really helped to bring down the burden, but how long can we proceed without resistance developing is a question we'll have to answer in time to come.
So we don't have much time left. Let's say we have about 5 minutes to wrap up, because I know Niels has to run to another meeting inside the WHO. But there is another question here put up anonymously, which I think is worth considering as we wrap up. Are there useful comparisons one can draw between communal acceptance of testing and treatment for malaria versus HIV/AIDS?
So I've often thought in the Southern African context where we have a frightening burden of HIV, one of the things that's easier about malaria is that there's no stigma attached. We don't have the political interference that South Africa suffered from when we should have been starting to treat HIV. So I think both of those have made malaria a low-hanging fruit. We have a treatment that can be completed in 3 days. It's not lifelong. And so I think for all of those reasons, we hope to achieve malaria elimination long before we're going to be able to eliminate HIV.
Thank you. Does anyone else want to come in on this? No. I think the point you make about malaria and the lack of stigma, I saw Rajitha nodding as well at this point, I think is very, very important. I suppose that is, you know, we're seeing this with COVID as well. There's a lot of stigmatization, and where there is stigmatization, where there's stigma, there is resistance, a lack of collaboration. So hopefully, I mean, a common fear of malaria, recognition that it can kill, and an enemy in a visible mosquito, perhaps, you know, can unite communities in relation to this disease. So very quickly, before we wrap up, can I invite perhaps the other way around, Rajitha first, Karen second, and Ian at the end, to just give us a very quick sort of one-liner on the importance of malaria eradication and its possibility, please. Rajitha?
Yes, malaria elimination is possible, but I think eradication is a long way off. There not only has to be commitment from individual countries, there also has to be cooperation between countries, because as Karen showed, borders are porous, as well as institutions, financial support has to be sustained and committed. Thank you.
Thank you, Rajitha. Karen?
I think that for me, the most salient statement was Rajita's comment about good public health systems, good health systems being in place. And to me, in many ways, I think malaria is symptomatic of improvements needed in the health systems. It's a preventable and treatable disease. And when we all work together, we can achieve great things. But when our health systems are fragile and erratic, then I think we see the ups and downs that we've faced with malaria, at least in this region.
Thank you. Thank you. And Ian?
I think that in treatment,
can't hear you, Ian.
we cannot.
Yeah.
Okay. Can you hear me now?
Yeah, I can hear you now. Yeah.
Okay. I'm sorry. I just want to reiterate that we cannot take for granted having effective treatment for people suffering from malaria, and we must protect artemisinin and resistance developing against it as much as possible. And we need to take very, very seriously the threat of resistance, because there still is not any other effective treatment for malaria, and we need to do everything we can to protect against resistance developing. And we also need to carry on research to discover other effective treatments in the case that resistance will develop.
Thank you. Thank you, Ian. And thank you, everyone, for your patience, your contribution. These are not easy events, because you have to present so quickly. But you've given us a very, very rich sort of understanding of your work in the little time available to you. And we are very, very grateful. And thank you to the Wellcome Trust and our colleagues in WHO. So look forward to discussing your work with you in more relaxed opportunities in the future, in post-COVID futures. Thank you very, very much all for joining us, including those who are online to listen in. Thank you.
Thank you.
Niels, over to you. Okay, so Neil, shall we now leave the meeting?